Welcome to 2025's Boot Camp Day 5 session called Preauthorization and Medical Necessity and Utilization Review. We're making our way through the workers' compensation obstacle course, and we're heading over to the swing challenge. This is where you're going to swing your pre-auth request to the utilization review agent and hopefully get a response back and swung back to you so that you can proceed with treatment for your injured employee. The learning objectives for today are: we want you to know what the statutes and the rules say about medical necessity in the labor code and the Texas Administrative Code, also known as the rules. We want you to know the treatment guideline, the evidence-based treatment guideline for non-network injuries and how it works. And then to understand the steps through the process of requesting pre-authorization and appealing it and going through all of those steps. That's what this topic is today. Before we get started in the content, let's talk about a disclaimer, and that is everyone out there, whether you're an employer, a healthcare provider, a utilization review agent, or insurance carrier, you all have a responsibility to know the statutes and the rules. And in this topic, we will both be using the insurance code, which is a law, and the labor code, which is the workers' comp law. We use both in this presentation, and the administrative codes from both sets, Texas Insurance Code and Texas Labor Code. So we're doing our best to educate you, but ultimately it is your responsibility to know the statutes and the rules. An overview of what we're covering today is, first, we'll talk about what does the statute and rules say about medical necessity? Where do you get that language? How do you know how to document what's medically necessary in our system? What services require pre-authorization? We'll go through those. What are the steps to conduct utilization review and request pre-authorization? And then after those steps are completed, going through the independent review organization process, the IRO process. And then our resources, of course. Let's start with what is medically necessary in the workers' compensation system. The first statute I'll take you to is the Texas Labor Code, section 408.021. This is our injured employees who have injuries in the workers' comp system in Texas. They are entitled to all reasonable health care that's necessary, as long as it is medically necessary for the compensable injury. There is no closing of a claim as long as it meets those two criteria. The statute says that the health care should be curing and relieving the effects naturally resulting from the compensable injury. Notice it does not say curing and relieving the effects of everything that was pre-existing. It is all the things that were related to the compensable injury. Also promoting recovery. Are the healthcare services you're providing to that injured employee getting them better? Are they functionally improving? And are they able to get back to work if it's safe and appropriate for them? We want the services that you provide to enhance that ability of the injured employee to return to or retain their job after an injury. So that is 408.021. All injured employees are entitled to medical benefits as long as it's medically necessary for the compensable injury. So this is the umbrella labor code citation, if you will. The next one is from the general definitions part of the Texas Labor Code, 401.011. It defines what health care is when it's reasonable. And those are, is the health care clinically appropriate? Is it effective? Is it going to work to help relieve and cure the effects of this injury? Is it provided in the best practices consistent with evidence-based medicine? We'll talk about those treatment guidelines that are evidence-based medicine. So is what you're providing to this patient evidence-based? Are there scientific studies behind how effective this treatment is? And then there are those treatments that don't have evidence behind them. Not yet, at least. If it is a treatment where there is no scientific study it still can be provided as long as it's justified in our system, and it must be consistent with generally accepted standards of medical practice that's recognized by the medical community. So that's the definition for healthcare reasonably required. Also, in the labor code and the insurance code, remember we have non-network injuries and we have certified workers' compensation healthcare network injuries. So we're using both the labor code and the insurance code in this instance, where we talk about the presumption of reasonableness and then guidelines and protocols from the network side of the insurance code. So medical services are presumed to be reasonable if they're consistent with the treatment guideline. We'll go over that treatment guideline for non-network injuries during this presentation, or medical services that are approved through utilization review. Say you've built a case for something that needed pre-authorization, you've obtained approval, then that's presumed to be medically reasonable and presumed to be medically necessary in our system. So we'll talk about the treatment guidelines and the UR process during this presentation. Continuing on with more statutes, also from the insurance code, 1305 is the network section, guidelines and protocols, and then 413.011 of the labor code that talks about our treatment guidelines. All treatment guidelines, the non-network and those adopted by each of the networks, must be based on evidence-based medicine. That means there's scientific studies that have been conducted that shows that that medical service has worked. It's also scientifically valid. So those scientific studies are valid and outcome focused. We want to make sure that our injured employees have a good outcome from the services you're providing to them. Also, guidelines, they're designed to help reduce excessive or inappropriate medical care while still ensuring that our injured employees get the right care at the right time. These are not black and white prescriptive instructions for your doctor. These are guidelines that's backed by evidence-based medicine. The treatment guideline for non-network injuries is called the ODG, or Official Disability Guidelines. We have two guidelines. One's return to work guidelines, and this one is the treatment guidelines. This product is commercially available. It also has return to work pathways, but we don't use those. They're not officially adopted. We use the treatment part of the ODG. And I will navigate you there in a few slides here, but remember that this guideline is comprehensive. We only use the treatment part of the ODG. Here are the telephone numbers and the URL to obtain this. It requires a purchase. It is a subscription. It is a living, breathing, digital document. So if you have a book, it probably has been outdated by now, because again, scientific studies happen all the time. The ODG reviews them, and adds or doesn't add to their treatment recommendations and treatment that's not recommended. On the network side, there's about 26 networks out there. If your doctor is signed up, or your hospital or your clinic is signed up to be a network provider, in that contract, it is required that they name their treatment guideline that they use for treatment for their injured employees. Now, I hear that some of them use ODG, but they don't have to. Check your network contract. More information about those guidelines and protocols can be found on the Insurance Code, Administrative Code 10.83, Guidelines and Protocols. So ODG for non-network and some of the networks, and then the network, check your contract to see which treatment guideline they use. Once you get that access to that subscription, you can get into the ODG product and you can search for treatment recommendations, conditionally recommended or not recommended, by diagnosis, by types of treatments. You can look at the treatment tab, which I'm going to go to, and you can also drill down to the medical evidence, those actual scientific studies that they used to create the treatment guideline. Also, in the ODG, we know that Sometimes you want to provide services that is not recommended by ODG. There is a section that you can document to build the case to submit to the utilization review that your patient needs this treatment for these reasons. Remember all of the statutes we've talked about. It's got to cure and relieve the effects. It's got to enhance their ability to get back to work, and all of those statutes and the language involved here. But ODG also has this section, Appendix D, for guidelines for documenting this service. It says that you should document the treatments that are not recommended, and it requires more extensive and detailed documentation so that you can talk to the URA in your position statement or in your pre-auth request. And then you need to explain the extenuating case-specific circumstances of your injured employee. Provide a clear and reasonable justification for going outside of what the treatment guidelines say. So just to put a point on this, just because ODG does not recommend it doesn't mean you can't provide it to the injured employee. It will need pre-authorization. You'll need to go through the steps that we talk about in this webinar and look at ODG's Appendix D for guidelines on documenting that position and that justification. You'll find Appendix D here, and I will show you. I will go to the live subscription in just a moment, but once you get to the treatment tab and over on the right, click on treatment info, and that drop down will occur, and documenting exceptions - Appendix D will pop out there. Also, the drug formulary can be found in ODG. This drug formulary is used for both network and non-network injuries. So this is universal. The pharmacy formulary is for all injured employees. And the list of drugs can be found in ODG's Appendix A and also on our website. And the N status means needs pre-authorization. I think ODG means the N. The N means not first line drug, but in our system, just for practical purposes, you can say N means needs pre-authorization. So again, it's in the subscription, Appendix A, and you can find it for free on our website, and Patricia has posted that in the chat. And I'm going to go over to the live version of ODG right now. You should be seeing the dashboard here for ODG. I have a subscription to get in here. Remember, I told you that ODG also has duration information. In the Texas Workers' Compensation System, we've adopted another guideline for duration, which means return to work guideline. So we're not using this part of the ODG, that's MD guidelines. This is the section that we're using, the treatment section. This is where the Appendix D can be found right here. Also, the formulary can be found here. This is your list of drugs. The ones that have a circle here with an N, that means needs pre-authorization. The ones with a Y do not need pre-authorization. And this is both for network and non-network. I'm going to go back to treatment for a minute here and say I want to look at all recommended treatments for low back. We have a lot of injuries that involve the low back. So you can see all of the treatments behind here. These are recommended, conditionally recommended. So with those circles. Now there are videos out here on ODG once you purchase this subscription where you can learn how to navigate. But I kind of wanted to give you a live version of this and what it looks like. Now, if you wanted to look at not recommended for low back, here are all the not recommended. That means you need to get pre-authorization if it's not recommended and build your case using the Appendix D. So remember, if there's no evidence, doesn't mean you can't provide that service to the injured employee. You just have to build your case during pre-auth and if you have to appeal any denials from there. Now to go back to the presentation. There's Appendix A again. Now, what medical services need pre-authorization? I've been talking about it a little bit with the pharmacy formulary and the recommended and not recommended, but we'll go through this first for non-network injuries. Remember, your intake registration team needs to be identifying these cases as network or non-network. Once you know that it's a non-network injury, the rule 134-600, this is your pre-auth rule for non-network injuries, can be found under R for rules and go to chapter 134. This rule is kind of long. It has a list of non-emergency medical services that require pre-authorization. Some of them require a little bit of reading, and conditions are in 1 through 12, but that is our list of services that require pre-authorization. So some of them are including, I think 11 and 12 say treatments and services that ODG does not recommend or address. So you've got a list of 1 through 10 services, and then 11 is treatments and services that are outside of what ODG recommends. I showed you how to find that on the ODG dashboard under treatment. So if it's not in 1 through 10, you look at ODG. If it's not recommended, then you're going to need pre-authorization. And then the last one in 12, it says that drugs not included in the pharmacy formulary. That's for both network and not network. I wanted to make a special note here. Office visits do not require meaning before the office visit, pre-authorization. They are subject to retrospective utilization review, but they do not require pre-authorization. So you won't see office visits in P1 through 12. So this is where you go get your list, if you will. Here's a decision tree for you to help explain what I just talked about in a better illustration here. So the main question is the treatment your doctor wants to provide to this patient on the list of non-emergency healthcare services that require pre-auth, or say it's concurrent review where you're in the middle of 12 PT sessions, you're getting to the end and you want to concurrently re-up that and get 12 more sessions or whatever. That's concurrent review. So this happens all before you provide the service, right? So is it on the list? Yes, then you'll need to ask for pre-authorization. If it's not on the list, does ODG recommend it or not? If ODG does not recommend it, then you're going to need to get pre-authorization. If ODG recommends it, then you can provide it without pre-authorization. But all services are either going to be looked up front because it requires pre-authorization or concurrent review, or on the back end after you provide the service, bill the bill. A carrier can look at it retrospectively for utilization review. But this is your decision tree for your pre-auth team to know what services need pre-authorization or not. So what we talked about non-network. So what network medical services need pre-authorization? First, you're going to have your contract available to the right people in your office, because in that contract, it should tell you what services require pre-authorization. Now, your contract may say use the list in 134-600. I don't know. I don't have access. We don't have access to your contract. So make sure your intake staff, your pre-auth staff knows the contract so they can decide what needs pre-authorization or not. Now, the pharmacy formulary does cover both network and non-network. So that applies in both scenarios. And we'll talk about pharmacy formulary here, but for network, again, check your contract. Here's an illustration that shows you how the pharmacy formulary works. Remember, it's for all patients, all injuries, all workers' compensation injuries follow the same illustration here. Now, I've worked with formularies before. Usually, in the commercial health world, it's a list of drugs that can be prescribed without pre-authorization. In our world, in workers' comp world, it's sort of backwards. It's a little bit different or opposite. We include all FDA-approved drugs in our closed formulary. All FDA-approved drugs don't need pre-authorization unless those drugs that are excluded from our formulary, the drugs that have status N. You'll find that in the Appendix A or on our website under N status drugs or under P for pharmacy. So those drugs that have an N status, even though they're FDA approved, they have an N status, you need pre-auth. Any investigational or experimental drugs need pre-authorization. And then lastly, all compounded drugs. And it doesn't matter what the ingredients are, just because it's compounded, it needs pre-authorization. Even if every single ingredient is not an N status drug, you still need pre-authorization just because it's compounded. So just to take a look again, all FDA approved drugs are within our closed formulary. The excluded ones need pre-authorization. So what is utilization review? What are the regulations that cover utilization review in our system? First, for network claims, here are the citations I wanted you to have. Often we get calls that people want to know where it actually says what. This is your list of citations for utilization review, network claims. Comes from the Insurance Code 1305 and the Utilization Review Agent section of the Insurance Code 4201. We're going to talk about both of those going forward in the rest of this webinar. The rules that go along with 1305 and 4201 come from the 28 Texas Administrative Code Part 1. This is the TDI section of the rules. They cross over into workers' comp for network claims. Chapter 19 goes over the licensing and regulations of utilization review agents. And then subchapter U goes into specifically UR for healthcare provided under workers' compensation insurance coverage. And then chapter 10 goes through the UR steps and retrospective review. So these are your regulations for network claims and utilization citations, utilization review regulation citations for non-network claims. We're going to, again, use some of the insurance code, and that's 4201 for URAs. The chapter 19, which covers UR processes that cover both network claims and non-network. And then specifically, we've talked about 134-600, which is their non-network pre-authorization rules. So utilization review is the insurance carrier's review of medical services for medical necessity and appropriateness. And they're conducted by a certified utilization review agent. Sometimes it has a different name. This company has a different name than the insurance company, but these insurance companies contract with certified utilization review agents. It is good for your intake staff and your pre-authorization staff to know who the URA is for this injury. So just a special note here, only Texas Department of Insurance certified URAs can conduct utilization review. They have to be certified by us. That's part of TDI's responsibility is URAs apply for certification and they get registered with us as a certified URA. That means they know all the rules and they follow all the processes in those chapters I've mentioned. I wanted to mention that adjusters, even though they work for the same insurance company, adjusters usually not part of their adjuster license, they are not certified or registered as utilization review agents. They may not conduct utilization review. Let me translate that for you. An adjuster cannot make a medical necessity decision. That person, that license does not allow them to make a decision whether the service you want to provide is medically necessary or not. Your requests and communications should go directly to the URA, and then your timeframes and steps will all be connected to the certified URA. So just make sure, no harm in communicating with the adjusters, but know that your pre-auth request needs to go to the pre-auth company, which is the certified utilization review agent. Also in 180.1, this is in the Texas Administrative Code, also known as our rules. it talks about utilization review doctors. These physicians performing UR must hold appropriate credentials. They must be of same or similar specialty as the physician when it's a physician requesting a pre-authorization, and they must have a Texas license. Now, if it's a dentist requesting services, then a dentist has to be properly licensed as a dentist to review that pre-auth request, or chiropractors the same way. They must be appropriately licensed. Now, this changed back in 2021. So again, the UR doctor, if you will, has to be of same or similar specialty as the one that's requesting it. Now, the utilization review definition of denial is called adverse determination. That's when the utilization review agent has made a determination that the services you propose to be provided are not medically necessary or appropriate. That's an adverse determination. This does not mean that they're saying, we're denying you because you didn't get pre-auth and you should have. It's actually speaking to the medical necessity of the services that you are proposing to provide. Let's talk about prospective. That means before the services are provided, prospective utilization review. We know that carriers and their URAs can look at services before they're provided, because some services need pre-auth, during, which is concurrent, and then retrospectively. I'm going to focus in on prospective utilization review. For the non-network side, we talked about Rule 134.600. That's the long title there: Preauthorization, Concurrent Utilization Review, and Voluntary Certification of Healthcare. We'll call it the non-network pre-auth rule. So the requester, sometimes it's an injured employee, but most of the time it's you, the healthcare providers out there. When you're making a request to the URA, this request should include certain items that are outlined in 134.600. Of course, demographic information, so the utilization review agent can know who you're talking about. So the name of the injured employee, the specific health care. Now, our rule does not say you need to put HCPCS or CPT codes here, but you can if you want. But you can describe the healthcare that you want to provide to your injured employee here, the number of treatments, and the time frame in which you're going to complete this. A special note here: if you do give yourself a time frame, if you're going beyond the outside of that time frame, you need to contact the URA to extend that. So giving yourself a time frame there. Also, most importantly, your information to substantiate medical necessity. I want you to understand that if you do it right the first time, then perhaps you don't have to go through an appeal of an adverse determination or even to an independent review organization. So do your best to substantiate it up front, because we already know that this service needs pre-authorization. Maybe it's not recommended by ODG. You'll have to be using the Appendix D to help you document and using those statutes that are at the beginning of this presentation. Also know that there is no special DWC pre-authorization form. Most of these forms you create in your office. Just make sure you have each element from Rule 134.600 in there. You should also include a phone number and fax number for your office. Make sure it's something that they can reach your doctor, reach the person that can have that discussion if they do call. Make sure that's accurate and give some hours around it if you can. It's not required by rule, but phone number, fax number, and the name of the requester and their professional license number or their NPI, National Provider Identifier. Or if it happens to be the injured employee or their rep, put the name of the employee that's requesting that pre-authorization. It's rare, but it can happen. The name, license, or NPI of the healthcare provider who will provide that service. So it's one who is asking, who's going to provide it, and the name of the facility. I know there are some facilities listening in today, so you need to make sure that pre-authorization has been obtained for the procedure that's being done in your facility. Make sure that's there on the pre-authorization request. So one, who's asking, who's going to render and perform that procedure, and if it's done in a facility the name and the MPI of that facility, and the estimated date that this is going to happen. So that is finishing off your pre-authorization request. Now, the URA we've swung it over to the URA. The URA has a response. They have a time frame to respond to your request. So I want to note here, if you send it to the adjuster, there's going to be extra time between the adjuster getting to the URA. Best practice is to get your pre-auth request to the right people that have rules to follow and that are certified by Texas Department of Insurance. So the URA must either approve or issue an adverse determination, which is also known as a denial, within 3 working days, also defined in our statute, working days of receiving that request. Also, the URA must send written notification within 1 working day of the decision. So if they make a decision on Tuesday, they need to send that decision within 1 day to the injured employee and the requester of the outcome. So again, all of this time frame starts when you submit your pre-auth, you swing your pre-auth request to the utilization review agent. So their initial response can either be an approval or a denial. Now, we say in the rule that each request and their decision will be based solely on one issue, and that is medical necessity. This whole process is all about medical necessity. So it should be regardless of any outstanding disputes on extent of injury or compensability. So they have to make a decision, yes or no, it's medically necessary or not, because compensability extent are totally different questions. The URA only is answering whether it's medically necessary or not. Or it's also regardless of the insurance carrier's liability. So the URA has to respond with an approval or denial. And also we wanted to make sure you understand that even if some injured employee has reached MMI date, which is maximum medical improvement date, the URA needs to respond with whether the services are medically necessary or not, because we know our injured employees can and do receive medical services after reaching that date of MMI. Their medical services do not cut off, it does not close after they reach MMI. So again, the pre-auth company has to answer whether it's medically necessary or not. If their response is that they've approved, then they're going to send you in writing an approval. And that should include the specific healthcare that they're approving. Your pre-auth staff should look at that very carefully and compare it to what you asked for. Make sure it's exactly the same. Clear up any discrepancies there. They should also have the number of approved treatments and specific time frame to complete those treatments in that approval letter. And then remember, it's regardless of any outstanding request for, outstanding dispute on compensability or liability or extent of injury. But they also have to put on that approval if there is an outstanding request on compensable extent, relatedness, or liability. So they can say, yes, we think it's medically necessary, but at the bottom, and you have to look for this closely, they're going to let you know if there's any outstanding PLN 1, which is compensability dispute, or the others on a PLN 11, say extent of injury or relatedness. So your pre-auth staff needs to be on their toes. Just because they got an approval, they need to read it very carefully. Also, the pre-authorization approval number should be on that response. Now, once they issue that approval, can they withdraw or change any of the elements that you requested in the first place? Once they issue that approval, the URA or even insurance carrier or adjuster, they can't withdraw it. Once they say it's medically necessary, then it's done. Also, they may not condition or change any elements of your initial request. That's why I'm saying the pre-auth team needs to look carefully at what you requested with what's approved, because the insurance carrier cannot change any of that unless they have a mutual agreement between your healthcare provider and the insurance carrier. And that's in writing. That agreement, say you asked for 22 physical therapy appointments, and they call you and say, we think only 12 should be approved, and here are the reasons why, and you agree to it, then that should be in writing. So there's a condition in which they can adjust it, but it has to be agreed upon by both parties and documented. But generally speaking, they cannot withdraw once they say it's medically necessary. Now, once you have that approval, does it guarantee payment? It's a yes and a no. I know that's confusing, but remember that the UR request, the pre-authorization request, is just asking for, do you think this is medically necessary or not? So once they say that it is medically necessary, they can't deny you on the back end for medical necessity. So in that case, yes, it is guaranteed that they can't say it's not medically necessary if they've said it was medically necessary during pre-auth. However, the insurance carrier can deny for other reasons. Remember that compensability, extent, or relatedness are not a question of medical necessity. They are other issues. So yeah, you can get a denial. Or maybe you billed it wrong. Maybe you didn't put a modifier on the billing. So I guess overall, it's not a guarantee of payment because you've got to make sure that compensable, extent, relatedness are taken care of, and your billing is correct. Now, if they respond with an adverse determination, so that was the second option, they can either approve or they can deny. This is covered in Chapter 19 of the TDI Texas Administrative Code, 19.2003 in definitions. Adverse determination is when the URA says the services that you want to provide or propose to be provided are not medically necessary or appropriate. That doesn't mean that you failed to ask for pre-auth when you needed to get pre-auth. So it's all about medical necessity, and it's not a determination whether those services are experimental or investigational. You'll find this language in 19.2003. So again, it's just the URA saying, we don't think it's medically necessary. When you receive that adverse determination, you should get it in writing. It should have lots of information for you to study and look at and try to digest. So it should have the principal reasons for the adverse determination, a clinical basis for that adverse determination. Your doctor and your pre-auth team needs to look at this closely. Also, a description for filing a complaint. Say you think the URA took too long to respond to you. There should be information there on how to file a complaint with TDI. Also, the professional specialty and Texas license number of the physician, doctor, or other healthcare provider that made that adverse determination. Remember, it has to be same or similar specialty. So look at that closely. Also, the URA's complaint and appeal system information should be on that piece of paper denying or the adverse determination denying the services you're asking for pre-auth for. Also, the source of the screening criteria or treatment guidelines used to make that adverse determination. In the non-network world, it's ODG. But what other screening criteria did they use? And on the network side, what treatment guideline did they use? Also, information on the IRO process, because that would be next after your appeal. And the form LHL 009, that's a request for an IRO. Or they give you a link to get to that IRO form. You can also find it on our website under F for forms. Just a note on when an insurance company, a URA, uses a peer review report to make that adverse determination. So maybe they're citing the source and they're citing a peer review report. This is covered under Texas Administrative Code 180.28, peer review requirements, reporting, and sanctions. So it says if they're going to use a pre-auth request, they must, if a peer review report is used to deny, that peer review report has to document the objective medical findings and the EBM, the evidence-based medicine that supports their opinion. So it's got to have the peer reviewer's name and Texas license, their qualifications, and all the medical records and documents they reviewed. This is important for you because maybe you have an imaging or another record that they didn't look at. So look at all the documents that they used to make that peer review report, a summary of the clinical history, and an explanation of their peer review decision. So if you're getting an adverse determination based on a peer review, ask for a copy of it and look for that information. In our Rule 133.308, it also notes that if they used a peer review report and you go all the way through the process and an IRO overturns that denial, they can't use that same peer review report for subsequent denials for that same exact medical service. So I just wanted to add that in there if the carrier is using a peer review report to deny and issue an adverse determination. Also on that note, what the carrier can't do, you'll find a list of things that are considered an administrative violation by the insurance carrier in the Labor Code Statute 415.002. There are several listed in this statute, but one of them says that an insurance carrier or its representative cannot say, we're denying all future medical care. It can't be in writing or said for our injured employees because of the statute I first talked about, 408.021, and that is that our injured employees are entitled to receive all medically necessary health care that relates to the compensable injury. So if you see that where they're making a statement, this person doesn't need any more medical care, that could be a violation. So before they issue that adverse determination, they must afford you, the requester, the healthcare provider of record, a reasonable opportunity to discuss the plan of treatment before they issue that adverse determination. They must have provided the URA's telephone number. They have to document this effort to talk to you, and it should be a good faith attempt to contact you. Sometimes we hear that they call on Fridays late in the day. They should be giving you an opportunity to talk to the peer reviewer during normal business hours and before issuing that adverse determination, no less than 1 working day. So you back up 1 day from the last day they're supposed to respond to you. That's when that conversation should be taking place. So they have 3 working days to answer formally with an adverse determination or not. So if you back up to the 2nd working day, that's when, if they're going to issue an adverse determination, that's when that conversation should be occurring. We want it to be a meaningful one. Now, on the 3 days, I wanted to mention, if you are submitting a request for pre-authorization on a Friday, the first working day of those 3 days is Monday. Okay, so it's the next working day is day 1. So if you issue your pre-auth request on Monday, then Tuesday is day 1, Wednesday and Thursday from there. So this discussion, so that 1 day before the 3 days ends, this discussion, we want it to be meaningful, and it must include, at a minimum, a discussion of the clinical basis for that URA's decision to deny you, and a description of the documentation of evidence that you could submit that might impact or overturn their adverse determination. This should be meaningful, meaning that you may know after that discussion that they're missing that MRI report, or they're missing evidence that they had a psychological evaluation before a spine surgery. That's sort of a prerequisite. Maybe they're missing that information. So that conversation should take place before the final day. So if you do get the adverse determination and the discussion doesn't change their mind, then you're going to receive that adverse determination and you can ask for a reconsideration of that. That's an appeal, if you want to call it, or a request for reconsideration. That's a formal process in which you're asking them to reconsider. So if you haven't put together the justification on the front end during pre-auth and you're at the point where you need to do an appeal, you must do that either orally or in writing, but within 30 days of receipt of that adverse determination, on the non-network side, and on the network side, 30 days from the date on that adverse determination. That's a little bit of a nuance between network and non-network, but basically 30 days you have to appeal that pre-auth request and put together the documentation you might need to overcome that denial. You're going to need to address the reasons for the denial. So read that adverse determination and see what you need to overcome. What are their reasons for not thinking it's medically necessary? Remember the definition of medical necessity in the statute and in the rules. Use your treatment guidelines or screening criteria. Document exceptions. So even if ODG doesn't recommend it or the network treatment guideline, use your Appendix D and ODG to help you put together and build a case to justify that treatment. And add any MRIs or evidence of missing information. And do not miss your deadline because it could end right there. So those are my best practices of overcoming and appealing an adverse determination. Now the URA has the swing again, and they must respond to that appeal, your request for reconsideration. And they have, as soon as practicable, but not later than 30 days after receiving your appeal request, or if it's for concurrent review within 3 working days. So they have 30 days from there to respond to your appeal. If their response to that appeal is another adverse determination, so now you've got 2 adverse determinations, you can request an independent review organization. That's a separate company that's not contracted with the carrier, doesn't have anything to do with the utilization review agent that just denied you twice. You can ask for an IRO to look at it. On the non-network side, it's no later than the 45th calendar day after you receive that second adverse determination. A little nuance here on the network side, it's not later than the 45th day after the date on that adverse determination. So basically for both 45 days. Remember, don't miss this deadline because that could end the process completely. You do want to keep it going. Can you start the pre-auth process over? Say you let the deadline elapse. This is where your pre-auth team needs to be on top of it, not to miss any of these timeframes, because resubmission and starting over with step 1 is very difficult. And there's only limited circumstances in which you can resubmit for the same exact health care. That is when you can document a substantial change in the patient's condition, or maybe like I was talking about for spine surgeries, it may require a psychological evaluation before a spine surgery. That could be a clinical prerequisite. Or maybe they're saying you should have tried conservative treatment first. Well, you maybe didn't submit the PT along with the surgery request. So those are the only 2 conditions in which you can start over. So remember that. You want to get it right on the front end. Use your ODG to help you navigate justification and building a case from the initial pre-auth to the appeal, and now you're at an IRO step. Just to give you a graphical illustration of the 3 main steps in the pre-authorization non-network process. The first big step is swinging your pre-auth request to the insurance company, specifically the utilization review agent. And then if they deny, you appeal, and then you ask for an IRO. So there's more information on this chart that you got in your handout that will be posted next to this webinar, so you can get a full page of this. On the network side, remember there's some nuances to the timeframes, generally the same 3 steps. Pre-auth request, if it's not approved and you're appealing, and then on to an IRO with the timeframes relevant for a network claim. Let's go and delve into the IRO requests and the LHL Form 009. LHL stands for Life Health Licensing, just if you're interested. This can be found on our website, but it also should be provided to you by the utilization review agent. This is a form that you fill out after you've gotten 2 adverse determinations and you're asking for an IRO. This form is to be filled out and sent right back to the URA. Do not send this form to us. It just delays the time frame and you can miss a deadline. So make sure that you fill this form out and send it to the URA. If you have questions about how to fill this form out, that can be, those questions can be directed to the Managed Care Quality Assurance Department of TDI. There's their telephone number, a toll-free number, and their email address at mcqa@tdi.texas.gov. So let's kind of give you some tips for filling this out. First of all, it's going to ask what the denied services are. You can take that information, lift it right off the adverse determination. This section doesn't require HCPCS or CPT codes. You can put them, but again, it's probably best just to look straight at the adverse determination to put it in there. And on the patient information section, there's a spot to put the DWC claim number. If you don't have it, you don't have to put it. Just say you don't have it. But if you know it, put it there. Also, there is a section for federal tax identification number. If you don't know it, you don't have to put it in there. This is for the provider that received the denial. If you don't know your FEIN, you don't have to put it there. Put NA. Also in section B, that is only to be filled out if it's different from section A. Section A is the person that received the denial or the provider of record, if you will, the healthcare provider. If it's different from B, then you would fill out B. So other than that, the last part of the form is where the release signature is. For workers' compensation, because we're exempt from HIPAA, you do not need to sign the release signature section. Now, the URA has sections to complete. You don't need to complete those. And the URA is the one that receives this form. It has to be received within the 45 days, and the insurance carrier must submit the IRO request back to MCQA. So that's their job. You get this form back to the URA, and then the URA sends it on to Managed Care Quality Assurance, who selects the next IRO to review your case. Again, it's an independent group of clinicians that look over the medical necessity denial from the carrier. This is an illustration of the steps that the IRO process takes. I'm not going to go over each of these in detail, but it has citations where you can get more information, specifically starting with 133.308 and then on through the chapters 140, 142. That gives you more information and it gives you the time frames. So this is after you've done your main 3 steps. Ask for pre-auth, appealed their denial, and then ask for an IRO. This is what happens after that. Now, a lot of people, a lot of healthcare providers have stopped after the first adverse determination because they think, erroneously, most cases, that they have to pay an IRO fee. Well, on the left-hand side, those are the cases where you don't have to pay an IRO fee. On the right is the only time that you would pay an IRO fee up front. So let's go over the ones on the left. And by the way, the fee is either $650 or $50, depending on the type of reviewer that's needed. So for every pre-auth review, whether it's network or not, you do not have to pay the IRO fee. For network, retrospective reviews requested by the healthcare provider, say it's an office visit and they deny for not medically necessary, you don't have to pay the IRO fee. And all retrospective reviews requested by the injured employee do not need the IRO fee paid by you. On the right-hand side, this is when the green side, when you have to pay the money. And these are for non-network injuries, retrospective reviews. That means the healthcare provided didn't need pre-auth, you provided it, and then the carrier denied for medical necessity on the back end. Those are the ones you're going to have to pay the IRO fee up front. If you win, you get your IRO fee back and payment on that service. So let your healthcare providers know most cases you're not paying the IRO fee upfront. You, as in the healthcare provider requesting the pre-authorization and the IRO. So an IRO decision is issued. What if you don't care for that IRO decision and you still want to appeal that decision? Rule 133.308, which is also on that step illustration, gives you the steps to appeal a medical necessity dispute. This is going to go on to the medical contested case hearing, or CCH, in our hearings department. Also, we would like you to know from 308, it says that the IRO decision is not an agency decision. So we're not considered a party to the appeal process, but this is the process you take to go to an IRO and to appeal that IRO decision. A benefit review conference, a BRC, is not a prerequisite to that CCH. So if you're appealing the IRO decision, you're going to go to a CCH or MCCH. Know that first responders have several citations in our law that allow for expedition of their cases. So first responder appeals of an IRO decision can be expedited to a fast CCH. The IRO is not required to participate in that CCH. However, we can ask for clarification from the IRO, but they're not participating in that CCH. So anytime you go to a hearing, the party that's appealing always has the burden of proof of overcoming all the information that people use to deny and uphold the URA's denial. So if you haven't put together your justification and built your case upon the first step, the second step, the third step, this is when you're going to have to put it together. So you have the burden of proof, like any party appealing. So, like I said, the CCH, the hearings department may send a letter of clarification to the IRO, but they can't ask the IRO to start over and look at it again, not to reconsider their decision, but just if they need something clarified, they can ask for that. The hearings are presided over by an administrative law judge, and they're going to be looking at the applicable treatment guidelines when they make their decision of that appeal of an IRO decision. So what's happening after an MCCH or a medical contested case hearing? If someone wants to go on from there, they're going to go outside of the DWC process to a judicial review. We're not a party to that judicial review, and we can charge the party that's appealing to the outside review for preparing documents to go on to that judicial review. Some important things I want you to know. Labor Code 413.042. This is an administrative violation statute that says you healthcare providers, you may not bill or pursue a private claim against a claimant for all or part of the medical service unless, a notice here, it doesn't say unless it's determined not medically necessary. That's not here. It's only if an adjudication comes from the Division of Workers' Compensation that the diagnosis that you're treating is not work-related. So you may not bill the patient if you've gone through all of those steps trying to justify your service, or even on a retrospective, justify a service that's already been provided. You may not bill the patient. You may not pursue a private claim to bill the patient for something that's been denied and you've gone through all of those steps. So lesson, get your pre-auth done right the first time. Hopefully you'll go through the process and done your best. The takeaways for this webinar is don't bill the injured employee if it's not deemed medically necessary. You can't resubmit and start over your pre-auth request only in very limited circumstances. So you need to know the definition of medical necessity according to our statute and rules, the treatment guideline that should have been used for that particular injury, or the screening criteria, how to document exceptions, if it's in fact an exception to the treatment guidelines, have any missing information, and don't miss your deadlines. Just to kind of recap what we've gone over. medical necessity, and the statutes and the rules that talk about medical necessity. What services need pre-authorization? We have a list. For non-network, check your contract for things that require pre-auth on the network side. The steps for pre-authorization and utilization review found in 134-600, and check your contract for the steps for network pre-authorization. The IRO process and the resources, which are Comp Connection. This is the fun part of the challenge today. We want to train your brain, see if you've committed it to memory, see if I've taught you well enough to answer these 5 questions. Let's start with question number 1. Which of the following is not true about the Labor Code's definition of healthcare reasonably required? Remember, it says not true. Clinically appropriate, effective for the injury, provided with best practices consistent with evidence-based medicine. And lastly, if evidence is not available, you cannot provide that treatment. The answer is the last. That is not true. Just because scientific evidence is not available for your service that you're proposing, you can build a case that the URA can consider. And then if they approve, then you can provide it to that injured employee. Number 2, the name of the non-network treatment guideline is the Official Disability Guidelines, or ODG. That is true. Remember, networks can use their own treatment guideline. It may or may not be ODG. The non-network required treatment guideline is ODG. Number 3, the utilization review agent, URA, must approve or deny each pre-auth request regardless of unresolved issues of compensability, extent, relatedness, or liability. And that is true, and most of you got that right. Very good. Remember, medical necessity is one question, and extent or relatedness is another question. 2 different. They're not the same. Number 4, does pre-authorization guarantee payment? Yeah, I said yes and no on that slide, but generally speaking, you could have a denial after you've received pre-authorization for other issues like extent or relatedness or billing issues. Number 5, after completing the LHL 009 form, request for a review by an IRO, the healthcare provider should send it to TDI. No, that is false. They should send it to the utilization review agent. So the LHL 009 form goes back from the healthcare provider to the URA. The URA is the one that sends it to us, or MCQA. You can always contact us with any questions at Comp Connection at 800-252-7031, option 3, or email us at any time at compconnection@tdi.texas.gov. We appreciate you attending and listening to this webinar today.